Hi everyone. In this talk, I will present our EPICOM paper titled FluSense, a contactless syndromic surveillance platform for influenza-like illness in hospital waiting areas. This work was done by me, Farsad Al Hussain, and my collaborators at Imar Samars, Andrew Lavar, George Khoury, Nicholas Ray, and Tohitur Rahman. So, what is the problem that we are trying to solve? If you look at the current program for influenza surveillance and forecasting by the CDC, we will be able to see that there is a huge gap in US's capability to track an epidemic or pandemic. During flu season, once the patients get infected, after the incubation and symptom onset period, they visit the hospital. Now, the US CDC primarily relies on data aggregated from these hospitals for influenza surveillance. However, there is a substantial lag time in the reporting of this data to the CDC. Here, we can see that reports of patient visits are only available 7 to 14 days after the visit itself, and during holiday period, this delay can be extended. This time lag is primarily due to the complexities on how virological testing and how hospital patient reports are handled and recorded. This time lag is a major threat for public health as an epidemic event has the potential to expand and spread rapidly without detection during this period. To tackle this forecasting gap, many internet based solutions are often proposed. However, they are inadequate because they don't measure the disease diagnosis or symptoms in real time. So, in this work, we try to mitigate the shortcomings with our platform FluSense. FluSense is a platform that collects data related to cough and population in hospital waiting rooms and attempts to reduce the time delay inherent to the current system. FluSense is a low-cost edge platform that listens to the audio and collects thermal images. It is a platform consisting of a Raspberry Pi, a microphone array, and a thermal camera. It also uses an Intel Neural Computer Stick for accelerating AI computation. Everything was put together inside a 3D printed box. Using this platform, we detected the number of coughs in the audio stream and counted the number of people from the thermal camera video feed. These are sample deployment locations for FluSense. In total, 5 units were deployed in different hospital waiting rooms. 2 of them were deployed in the main waiting room or walk-in clinic. Rest 3 units were deployed in the pediatric clinic, general checkup clinic, and women's health checkup clinic. At first, we built a cough recognizer for FluSense to detect coughs from deployment areas. We trained a CNN model for that. The model was trained on an augmented dataset that simulates different real-world challenging situations like background noise, speech, and room reverberations. The model was also transformed on top of the hospital waiting room data. In the end, we achieved an average F1 score of 0.88 for cough detection on a testing dataset collected from the hospital. For people counting using a thermal camera, we used a faster RCN model trained on Microsoft Coco dataset as our backbone. We transformed on top of that model using the thermal data collected from the hospital. Our final model achieved 0.9 mean average precision at 0.5 intersection over unit threshold for people detection. After building the system, we started testing the performance in the real world. First, we analyzed our people count detection system. We found out that after deployment, the number of people detected with the thermal camera has a 0.93 correlation with the actual patient visit count in the hospital. Then we analyzed our flu prediction capabilities. The above figures show the result for total ILI patient prediction and total flu positive patient prediction in the hospital using our system. From the image on the left, we can see a clear pattern as the number of coughs goes down and up with the number of flu tests. Also, from the figure on the right, it is evident that flu prediction models based on different cough-based features outperform flu prediction models based on different people counting or weekday-based features. Numerically, we achieved a 0.59 correlation score on top of the baseline score of 0.48, which uses just the day of the week and holiday indicator-based features for total test prediction. Similarly, we achieved a 0.4 correlation on top of the 0.29 correlation coefficient achieved by the baseline feature for the total flu positive patient count prediction. Finally, with multiple features, we get a correlation coefficient of 0.65 and 0.61 for total flu test and total flu positive patient prediction respectively. To assess the relationship between captured cough counts and total influenza testing per day, negative binomial random effects models are used. In invariable comparisons of this relationship for different rooms, the two walk-in clinic units and the pediatric clinic all showed a statistically significant relationship with p-value less than 0.05, while the checkup and women's clinic showed no evidence of a relationship. So, what can be done in the future? One option is that we can look into more diverse set of locations for more finer grained infectious disease modeling. We can also try to look into different types of cough and other kinds of respiratory sounds like sneeze, sniffle, etc. Other modalities like Wi-Fi, radar, tweet, or search, etc. can be utilized as different sources of information. So finally, this is the end of our presentation. Thank you very much to all of you.